Good morning, everyone. I just want to make sure that it is working. Good morning, everyone, and welcome to Journal Club today. Our first topic is Antimicrobial Stewardship in General Practice, Lessons Learned in Sweden's Strama program. And the presenter is Lesley Hawes from the Department of General Practice at Monash University. Thanks, Lesley.
Thank you, Arjun. Yes, I'm a PhD student here with NCAS, based at Monash Uni, and looking at antimicrobial stewardship in general practice, and I thought we'd have a look at a successful program in general practice and see if there are any lessons we can learn. So now, advance, here we are. Just a bit of background about Australian general practice. 87% of us, that's virtually all of us, will visit a GP at least once in any year. And for every 100 encounters, a GP will deal with 155 problems and 23 infections. And as a result of that, each year 45% of us will have an antibiotic dispensed. And in 2015 alone, that was 30 million antibiotics dispensed in the year. And we're a population of what, 24 million? And the three most prescribed antibiotics are amoxicillin, cefalexin, and amoxicillin clavulanac. So we're not talking narrow-spectrum penicillins. So how do we compare on the world stage? You can see, does this pointer work? Yes. You can see here in the middle, looking at OECD countries. Here's the OECD average, and Australia is well above average for the overall volume of antibiotics prescribed. But also note this pale area at the bottom here in pink, that's second-line antibiotics. So we use a lot of the second-line antibiotics as well. And why Sweden? Well, if you look right down here on the left, very much lower than the OECD average for overall volume of antibiotics prescribed. And I had to make sure the circle didn't overlap because they have very little use of second-line antibiotics. So what is the Swedish program? They call it Strama, which translates as the Swedish Strategic Program for the Rational Use of Antimicrobial Agents and Surveillance of Resistance. They have a web page which has some pages in English, but what I'm mainly going to use are two of the papers that they have published about their Strama program. The first was the 10-year follow-up, which was published in 2008, where they showed how that had already decreased antibiotic use in general practice, or outpatients as they call it, and without any increase in serious infections such as of hospital admissions for mastoiditis, rhinosinusitis and quinsy. The other paper I'd like to look at is their follow-up one from lessons learned during 20 years of Strama. And in this paper they describe the main strategies of the program and, more importantly, the lessons learned that could inform other countries. So just a very quick background about Strama. It started in 1995 as a voluntary network in local areas to help stop the spread of penicillin-resistant pneumococci. However, being voluntary, it lacked funding, closure constantly threatened, until the year 2000, when funding was obtained. And since then, it has grown. It's now multidisciplinary, it's coordinated, and it has continuously expanded. So it covers not only primary care, but hospitals, nursing homes, and daycare centres. It uses what they call a multifaceted approach, which is commitment at all levels, monitoring of antibiotic use and resistance. It promotes treatment guidelines to GPs. They use local respected experts to liaise with GPs. They have a national target for antibiotic prescriptions, and they can monitor for underprescribing. Communication is important, not only to GPs and health professionals, but to the public as well, for public awareness. They do education, again, not only to health professionals, but also the staff in general practices and new parents. And It's able to develop stewardship programs, and it also does infection control. Now, I won't be talking about all of these today, but I'll be talking mainly about the top few. So the commitment at all levels, of course, governments set healthcare policy, but they provide Strama funding, which is not insignificant. The figures given in the paper were nationally €2 million, local was €3 to €5 million, and that funds both the national level body and the local Strama expert groups. Our Australian funding, I could only find one figure of $9.4 million in the 2016-17 budget to continue the work, so it's comparable. And we also have national oversight. We have the Antimicrobial Resistance Prevention and Containment Steering Group, which is responsible for the implementation of our national strategy. And we get expert advice from the Australian Strategic and Technical Advisory Group on antimicrobial resistance. But we have no equivalent of these local Strama expert groups. Strama has a One Health policy. As you can see, there's a wide range of participants in their national level. They have infectious diseases control, reference groups for antibiotics, health and welfare, pharmacy, communicable disease control, local authorities, medical products, veterinary institute, Board of Agriculture. Ours too is One Health. Our steering group is chaired by the Chief Medical and Veterinary Officers. And the ASTAG Expert Advisory Group has a very long list of members too, of which I've picked out some, such as our Royal Australian College of General Practitioners, primary healthcare nurses, our Australian Commission Safety Quality, NPS, and so on, including us, NCAS and vets, of course. Activities now. At the national level, the Strama directly oversee information exchange, the national collection of data, the analysis, and some of the feedback of the data. They update the treatment guidelines. They identify gaps in antimicrobial stewardship and develop interventions. They support the local Strama groups, and they arrange the national forum. We also do those activities, but most are not directly done by our national oversight group. So we do information exchange. The data collection, I've spoken before about our data collection, and I'll briefly go through them again in the next slides. We've done beach surveys, and we now have NPS Medicine Insight program, and feedback goes through the Australian Use and Antimicrobial Resistance in Australia reports, or AURA reports. Our treatment guidelines are updated by our very excellent therapeutic guidelines. Gaps and interventions in general practice, we're not as systematic as they are. So we do still have gaps in general practice, and we are developing interventions, but not as systematically as Strama appears to do. And as I've said, we don't have these local expert groups to support GPs. And our national forum was last year organised by NCAS, and this year is to be organised at this stage by the CRE Reduced team at the University of Queensland. So just having a quick look at these expert groups, they have at least one in every county, and I believe they have 21 counties in Sweden. And they contain representatives from general practice, communicable disease control, infectious diseases, otolaryngology, paediatrics, clinical microbiology, and local pharmacy. And some groups will add others as required, but that's usually the minimum. They monitor prescribing at both the county and individual practice level. They also include diagnosis in that monitoring. They have regular meetings between these expert groups and each practice. And they work with the GPs on their antibiotic prescribing. They promote guideline uptake because of the monitoring. They know what the GP is prescribing for what, so they can promote guidelines directly to the GPs. They educate not only the GPs, but the practice staff as well. So it's a whole of practice approach to antimicrobial stewardship. And they can identify common problems in practices and any needed studies. as I said, we have no equivalent in Australia of this particular group. So the monitoring, they used surveys at initial stages. They conducted 3 in the year 2000, 2002 and 5. But from 2007, they have been extracting electronic medical records. They've been using 60 to 90 primary healthcare centres, which cover about 6% of the population. They have been standardising their data collection and evaluation over the years, and they're now monitoring for undertreatment as well. And from that monitoring, they can develop interventions. Australia, we also started with paper-based surveys. We had what we call the beach surveys. They were continuous sampling of GPs. So 1,000 GPs a year, continually rotating, each collecting data on 100 consecutive patient consultations. But that was defunded in 2016. We've now switched to the Medicine Insight program run by NCAS Medicine-Wise, which at their report date had 475 participating general practices. I believe it's much bigger now, which covered 6% of all general practices and 2.1 million patients, which by my calculations is about 8% of our population. However, these practices are not necessarily representative of all, as they seem to come from higher socioeconomic status areas. And monitoring of undertreatment is still future work in our Medicine Insight program. It provides feedback to participating GPs and also provides information for the ORA reports as well. Strama's national prescribing target is, at the time of writing of the paper, was 250 prescriptions per 1,000 inhabitants. They learned a lot of lessons in developing these targets. Targets should be based on epidemiological studies. They must include data on diagnosis-related prescriptions, use a representative patient population, include evidence-based guidelines, be regularly re-evaluated. They must be applied at larger than at one health centre level, because of course health centres differ. And you should monitor for undertreatment. So we have some ticks along there, but we're still working on some other areas. So as yet, we can't develop a target for general practice using all of those criteria. No national prescribing target. We lack the diagnosis data. We don't have yet integrated patient outcomes, and it may not be a representative population. So surveillance and tracking of resistance, their lessons were that you need good quality data with standardised methods. You need to collect hospital and primary healthcare data, but they note primary healthcare data may overestimate resistance because GPs don't take samples from every patient with an infection. They may only be taken after a treatment has failed or the patient has a prolonged illness. However, they still have low levels of resistance, and narrow spectrum antibiotics are now used for most infections in our patient care or general practice in Sweden. We also use hospital and primary care data in our collection with the same proviso with general practice. However, although we don't have high levels of resistance in our community, as I said before, our 3 most prescribed antibiotics are not narrow-spectrum penicillins. They're amoxicillin, cefalexin, and amoxicillin clavulanate. So something's getting lost somewhere. Treatment guidelines. Strama found the treatment guidelines should contain diagnostic criteria, analysis of antibiotic risk-benefit for the individual and society, when to re-evaluate the patient, and have simple treatment algorithms. And the key to getting these implemented is these experts who work closely with the GPs, the prescribers. They have access to the audit, they're able to give feedback and promote guideline adherence. But they acknowledge this does take sustainable funding. Our therapeutic guidelines do tick most of those boxes. However, they don't really readily integrate into the GP workflow in their current state. And we don't have the experts working with GPs. NPS medicine-wise is able to conduct audits, so they're optional for GPs to opt into those audits, and NPS can give them feedback if they join in, but if they don't, not interested, we're missing that group. And NPS has funding for all drugs, not just antibiotics. Antibiotics is just one part of NPS's remit. Communication was also key. Strama talked a lot about awareness raising and education, not only of course to prescribers, but to the public. Although it's not an overall program, it's been a key. They do a lot of communication and make sure the public are aware about unnecessary use of antibiotics. And European surveys have shown that Sweden's public has really good awareness about unnecessary use of antibiotics and the negative effects of antibiotics, which has decreased patients' expectations for antibiotics. So their lessons they learnt were that you should communicate the negative effects of unnecessary antibiotics to the public, and it has to be continuous. Our communication, we did have some direct, mass media messages, but they finished in about 2004. NPS Medicine-wise has information and fact sheets available for the public on their website. They have a pledge that members of the public can take. But we still know that up to 40% of our GPs will say that they will prescribe in response to patient demands for antibiotics. And at this stage, we don't really have any mass media. We have resistance fighters, but that tends to be, I think, more social media. And that's a worldwide thing that we are part of. So the key elements with Strama are the bottom-up approach, working closely with prescribers at the local level, the continuing strong political support and sustainable funding, and those local expert groups. So what lessons can we take from Strama? Well, there is no one solution to antibiotic resistance. We do have some key learnings that we could consider. One is, of course, public awareness is very important. Swedish population has good awareness. Our population is much less aware. Both countries have excellent national oversight of the program and do similar activities or oversee similar activities. A major difference is the support given to GPs in these expert groups. Our GPs don't have this ready access to people like infectious disease consultants. They can get clinical microbiology support from their private or path lab, and local pharmacy doesn't yet have good relations working with GPs, for instance. So we don't have that ready access that goes to visit each GP practice to give them support. So Strama can identify gaps and develop interventions. They can also monitor prescribing, including the diagnosis and the outcomes, which has enabled them to set a target. We're still behind in that area. They can promote the guidelines directly to the GP in response to the audits of their prescribing, such that Sweden now does prescribe narrow spectrum antibiotics in general practice. And of course, in both countries, sustainable ongoing funding is essential for all activities of antimicrobial stewardship. So to conclude, there are some valuable lessons for us in the first 20 years of the Strama program for us to study and see what we can implement here to help us establish antimicrobial stewardship in general practice. Thank you. Questions? Yes.
One of the structural challenges in Australia, you might need to repeat it, is the national funding for general practice and aged care and state funding for hospitals. Presumably a lot of the experts are building the environment actually coming out of the hospital sector. And so do you have any ideas of a potential model whereby these group of experts could people and how that would work?
What a great question to repeat. If the question was about basically our state-funded model for hospitals with the experts such as infectious disease consultants in there, and the federal funding for general practice. And for general practices, our experts are probably going to come from the hospital system. How can we integrate that better? I mean, if I had the ready answer to that, I think I would have finished my PhD by now. But we have to look at alternatives. We also have things like primary care networks, which liaise. That's one possibility. Whether we develop other models, de novo, look at something similar to local expert groups where specialists may be paid for their time to help GPs. I mean, there are still numerous options. Yeah. I mean, if you have solutions, good. Yes.
I don't have all the solutions, but I think just reflecting on what you've been presenting, I think it's really interesting, but I also think we have to reflect on that we work in a very, very different health system and funding model to that which exists in Sweden. And I get at least 20 emails every week at my clinic email suggesting that specialists are available to provide me with help, which I don't usually do much with, unfortunately, except in the rubbish bin. Because the thing is, what is the kind of time that you're going to be asking GPs? How do you embed quality improvement for antibiotics when actually the data isn't being collected at a PHN level to be able to provide feedback? So what do you think is some early steps? Because there's a lot of big stuff here.
Yes, there is.
What are some early steps that you think could be translated?
Data collection. I mean, without data, what do you have really? We really have to step up the monitoring of prescribing. We have NPS medicine-wise. There is also the new work being done by AIHW, the Australian Institute of Health work.
They'll be collecting data from a tool that doesn't extract data on infectious diseases or antibiotic prescribing.
Yeah. So whether that can be extended, yes. So the question was about what do we need? As I presented, it's very much big picture. Where can we start? And to me, I think we need to start with things like data and improve our data collection. So whether NPS medicine-wise can be supported to increase for all GPs, not just the ones who want to opt in. We have no sticks as such. It's all optional, whether we change standards. So there's so many things we can look at. Changing standards to make monitoring compulsory, for instance. Can the PHNs help? Can AIHW be expanded? Can NPS be expanded? We have resources there, yes. You've got...
just a comment about the GP NAPS, I think it's important.
Oh, GP, oh, sorry, yes.
This particular piece of work, I want to say one thing, that the outstanding finding from the GP NAPS was the information was actually in there. So they are actually putting in there. So
yes.
Although there was no indication attached to the antibiotic, the team were able to identify the reason for prescribing in over 90%.
Yeah.
And so really this comes down to introducing structural measures to extract data and make it easy for the GPs to attach the reason and codify those reasons. So this is pulling into line some of the work that we're doing in NAPS, in aged care and hospitals. And we actually think some of that is actually translatable, but clearly we can't have a resource intensive process like hospital NAPS where we've got pharmacists coming out of our ears, not really, but we do need to establish a meaningful passive extraction.
Yes. So just in case you couldn't hear all of that, that was about the GP NAPS program that NCAS has been running, extracting GP data. The data is there, but it was resource intensive to put it all together. So yes, sorry, I'd forgotten our very own GP NAPS. Yes, so that is a program that also could be expanded. As you say, the data is there in the medical record. It's getting it extracted. It probably needs some sort of a third-party solution to integrate everything. Yes.
I was going to get James to comment
yes.
on the vet situation.
Oh, the vet situation, yes.
Yeah, so I think currently we're looking at a natural language processing solution because as Kaz was saying, the information is in there, not in any really structured form, and it's difficult to extract, but there are ways of doing it. I was just interested in the fact that both in Sweden and in Australia we have a One Health approach, which seems to stop at the advisory level, and any of the implementation is all around. Do you think that raising public awareness might be easier if we actually had a One Health approach, so that when they went to their pharmacist or the dentist or the doctor or the veterinarian, where they may be getting antimicrobials being prescribed, that they can see that there's actually a link?
Oh, definitely. Yes, so the question was about public awareness and One Health approach. So a colleague from the veterinary stream has pointed this out, and yes, so at the top level it's very much One Health, but as it filters down it divides. I mean, Strama apparently has a veterinary stream too, but it's a stream, isn't it? I mean, I have learnt so much from interacting with my veterinary colleagues here, and I see a lot of parallels between general practice and vets. I mean, it's the same people going to one with their baby and one with their fur baby. And if you had public awareness, it would certainly help both of us. So yeah, public awareness is very important to reduce those expectations for antibiotics. And yes, I think veterinary practices and GP practices do have a lot in common, and we should be working more closely together. Yeah, I see more in a way in common between general practice and a vet practice, because both are private practices. I mean, you have dispensing in veterinary, we don't in general practice, but yeah. Yes, a lot.
I was actually quite happy that there was penicillin for the top 3 antimicrobials being prescribed rather than a whole range of other things that could have had a lot more important downstream.
And lots of symptoms for the guidelines to use.
Yeah.
So
Yeah.
guidelines might need to change.
But yeah,
Yes.
I was quite happy about amoxicillin.
Yeah.
It's a careful recommendation and for you
Yeah, keep going, it's fine, we'll just load up.
Yes, the comment was about, in case you didn't hear online, was about how it's fortunate our top 3 antibiotics are only amoxicillin, cefalexin and moxiclav.
Pretty much the same as what we can see in small animal practice.
Okay, and it's similar to small animal practice. I mean, we can't prescribe fluoroquinolones without authority as well. So I mean, I'm not a GP, but GPs can't. All right, I think we're getting ready for the next talk now. Any final questions while they finish setting up?
Thank you.
No? All right, thank you very much.